Just for today's session, I'd like to thank the funders who provide support for the webinars, the training, and all of the work that's done at the Canadian Cochrane Centre. I'd like to thank our funders, the Canadian Institutes of Health Research, for their support. I'd like to send a special thank you through to PAHO, who provides the license for us to use this software, for us to use Blackboard Collaborate, and to provide these webinars to you. Thank you so much to Luis Gabriel Cuervo and his team for their support. Today's webinar is on decision aids and their uses, chiropractic applications. And the webinar today will be presented by Tamara Rader with some support from Jordi Pardo. They're both based at the Centre for Global Health at the University of Ottawa. Tamara is the knowledge translation specialist for the Cochrane Musculoskeletal group. She helps to make the results of Cochrane reviews into products that can be used more widely, such as plain language summaries, decision aids, and advising on clinical practice guidelines. She coordinates a group of volunteers with musculoskeletal conditions who peer review and help prioritize research in arthritis and osteoporosis. As a medical librarian since 1998, Tamara has been helping to meet the information needs of researchers and health professionals in a variety of settings, including hospitals. So Tamara, I'd like to turn it over to you to go ahead and give today's presentation.
Thank you very much, Erin, and thank you also to everyone also who's been here and decided to join us today. So I will start with my very first slide, and as Erin mentioned, we'll be talking about decision aids, and especially we're trying and make it relevant to chiropractic practice and applications. So as you heard, Tamara, myself, and Jordi will be here to answer the questions, and I'll be doing the main presentation. Just to orient people in terms of where the information for our decision aids comes from. We are part of the Cochrane Collaboration, which is a worldwide organization with 50 groups around the world. Thank you very much for that. So, for those of you who aren't too familiar, the collaboration is made up of over 50 groups, and they're all classified by disease area. Our group, based in Ottawa, is the Musculoskeletal group, and we're interested in conditions that affect the bones and joints, such as arthritis, osteoporosis, ankylosing spondylitis, fibromyalgia, things like that. The main product of the Cochrane collaboration and the 50 Cochrane groups are systematic reviews. Each of the 50 groups, 50 disease area groups, follows similar methods to produce systematic reviews about the effects of health interventions. The interventions are very broad. There can be reviews on anything from medication, surgery, exercise, dietary therapies, chiropractic therapies. These methods are designed to make the review as objective as possible, so they're very methodological and quite heavy in terms of detail. So this sometimes means that because they report such a great level of detail, it can make the reviews themselves difficult for people to use in practice. They're often very long and dense, and certainly hard to put into context when you're sort of at the front line of the patient. So there are efforts being made across the collaboration to take the evidence from the Cochrane reviews and put it into context for clinical use. And one of these initiatives are the Cochrane decision aids that we're going to talk about today. So can you indicate by clicking on the green check mark if you've accessed a Cochrane review in the past or downloaded it? And if you haven't, you can put an X. But if anybody's actually opened up a review and read it or tried to use it in the past, that will give you some idea. So, okay, great, thank you. I see a lot of responses coming through now. Thanks a lot for that. That gives me an idea of the familiarity. So we have one more survey before we start. I would like to know what people know about decision aids already. So if you could, Erin will kindly change it to the lettered responses in the polling section. So this is our question. Please choose the option that is closest to your current situation or what you know about and use decision aids right now. A, I use decision aids routinely in my practice. B, I know what a decision aid is, and I have used them before from time to time. C, I heard about decision aids, but I've never used one. Or D, I never heard about decision aids, but I thought it's a cool topic, and so I registered to learn more. So if you can just let us know your familiarity with decision aids, that would be great. I see a lot of B's and C's coming through. That's terrific. We'll just leave it open a few more minutes and then read out the responses for our recording. Great. So we have about 5% of people, 3 out of 57, who have used decision aids routinely. About 13 people who know what a decision aid is and use them time to time. About 20 people have heard of decision aids but never used one. And no people have indicated, 5 people have indicated that they never heard about decision aids but are learning about them fairly for the first time. And we've got about 16 people who haven't responded. Thank you very much for that. That also gives us an idea of your familiarity level. So I'll begin to talk more in detail about decision aids. So our definition that we're working with today is here on the screen. It's a plain language tool for shared decision making between the patient and a practitioner. The practitioner could be any number of health people, nurses, chiropractors, doctors, anybody like that. It shows evidence for benefits of harms in a visual way, so hopefully making it a little easier for people who want their information at a glance. And it has the following characteristics. It helps people clarify the options and the harms associated and whether they work or not, their personal values, their preference. They can clarify their preferences, and any unresolved information needs, decisional needs that they have. And it also frames it so that a decision actually needs to be made. So it's slightly different from other patient education materials or patient materials that simply give information. It's actually more of a guide that leads into a decision to be taken. So the decision aids that we'll discuss today take evidence from a Cochrane review and package it with other information that somebody would need to make a decision. And it helps people clarify their thoughts, and it can be a real aid in communication with the chiropractor or health practitioner. So there's quite a team behind the decision aids because, as you can imagine, there are a number of areas of expertise that decision aids touch on. Many experts come together to define the decision aid, including at least one person who has the condition. So you'll see the bottom there that patients are also consulted and are involved in the creation of decision aids, so that we have a good idea of whether they meet their needs. So the process, we're lucky we're here in Ottawa, and there's a patient decision aid group based in Ottawa, and they've been very helpful in developing the methodology to create these decision aids, and so we've leaned on them also. At the bottom of this slide you can see the URL for the decision aid group here in Ottawa. The evidence for the options that we present is assessed for quality and prepared using something called the GRADE Summary of Findings Table and Evidence Profile. So GRADE is a methodology that many journals have adopted, including the Cochrane Library and Cochrane Reviews. And if you wanted to know more about how the evidence is assessed for methodological quality, we've got some other work listed there, some references that you can visit. These methods are part of the Cochrane process to ensure that the evidence is impartial as possible. Later in the presentation, I'll show you a summary of a findings table, which is the source of the evidence and uses these methods. In addition to meeting Cochrane standards, the decision aids must also meet international patient decision aid standards. These standards are mainly used to ensure quality of the information, but also to ensure that the options listed are balanced, and they guard against the use of decision aids to promote a certain product or intervention. So there's sort of internationally recognized standards for creating decision aids, which we adhere to. Here is just a quick slide that gives you some idea of the criteria. This is just a sort of screenshot from one section of it, but it just mainly ensures that all the criteria are there. There are 4 steps in the decision aid process. Before jumping into the information and the steps, we always begin by describing the intended target audience. We aim to describe the same type of people as were studied in the studies that make up the review. So we also give some background on the condition and the intervention so that we are clear about the context and the people that are affected. After the context is clearly described, the reader can navigate the 4 steps to prepare for decision making. So the introduction and background are the things like what kind of patients does this mean? I mean, sometimes it's quite simple to figure out that we're talking about adults, for example, and not children, but we still, because these are available on the internet, we like to be very explicit about the population that we're talking about. Step 1 will give some information about the benefits and harms of each option. Step 2 helps people clarify and make explicit their reasons to choose each option that matter most to them. Step 3 helps people to prepare for decision making by identifying any unmet information needs. And step 4 is a section where people can make their plan and write down what they want to do. Okay. Many patient education materials strive to be balanced and present the benefits and harms of options. One aspect that makes decision aids unique is the emphasis on patient values. Many times there is more than one acceptable course of action for somebody, especially somebody with a chronic condition. Decision aids try and help the person clarify their goals of treatment and their personal values and match these to the option that best supports their values. So the decision aids and the content, we try to provide information about the options in detail. We also want to give them an idea of probabilities, not simply saying whether something works, but what is the likelihood that someone will find relief from pain or mobility, other outcomes like that. And we also include some structured guidance to help people decide in guiding them through their deliberation and their communication with family members, healthcare practitioners, etc. At the very minimum, we ensure that the decision aid is developed to be balanced, rigorous, up-to-date, free of conflict of interest, or at least any competing interests will be disclosed so people will know the source of the information, and we try to use plain language. There may be more criteria that would apply if the decision aid uses a case report or storytelling or is in an electronic format. Okay, now I will take you through a case of a woman with acute low back pain who is considering having spinal manipulation therapy, an intervention that's often delivered by chiropractors. So as you see here, we have Janet. She's a 39-year-old woman who was playing outside with her children and bending over too much. And she had a difficult episode of low back pain, more painful than she'd had in the past. She initially took some painkiller and anti-inflammatory, and this was provided some relief, but she has she hasn't had a great deal of relief, so she's still looking for some help with her back pain. To make the decision, Janet needs to weigh the benefits and harms of using the therapy, spinal manipulative therapy. She needs to clarify her reasons for choosing the treatment that matter most to her. She needs to decide what else is needed for preparing for this decision, and she needs to decide her next steps. So here's a sample of a decision aid. It asks the question, should I use spinal manipulative therapy for acute low back pain? And this, by starting with a question, it really indicates what will be covered in this decision aid. So as I mentioned before, we like to say who the decision aid is meant for, because if someone downloads it, then they can orient themselves. We'll give an example of what we mean by acute low back pain, and we describe the therapy. We also give an idea to the person about how the therapy might work, or is meant to work, the mechanism of action there. We outline their options. They can use it, the spinal manipulative therapy. They can try this therapy, or they can decline it and discuss other treatment options. We also indicate if there's any health problems that would influence their decision. So these aren't necessarily things that have to do with their values. It's really things that have to do with their health that might influence their decision from a clinical standpoint. The next step, step 1, provides 100 faces. It's a visual representation of what the research shows, including the methodological quality using great evidence. So there's low quality evidence that 5 more people who received spinal manipulative therapy recovered after 1 month than those who received other interventions. And the other interventions were things like physiotherapy, exercise, back school, which is another type of patient intervention. No serious side effects were reported for using spinal manipulative therapy, but neither were any serious side effects reported for using the other therapies. So this gives Janet an idea of what she can expect if she were to try the treatment. Step 2 really asks the patient, what matters most to you? There's many reasons that they might want to try a new therapy, but we encourage them in a decision aid to identify their values and their goals for treatment. For example, how important is it for you to relieve your back pain? How important is it for you to receive treatment with minimal side effects? So we put the values, we clarify their values and put this evidence into the context of their decision making. And we try to make it balanced. We provide reasons to use the therapy and reasons to decline. At the bottom, we revisit the question, which option are they preferring at this point, now that they've seen the evidence? Perhaps someone will say they still don't know. They might want to try therapy, or they might just decline therapy after seeing this evidence. The next page, we ask people to realize or figure out how well this decision aid helped them learn the key facts. So we give them a sort of self-administered test on the information that we've given them, just to ensure that they understand the benefits and harms of the treatment. After that, we give them 4 questions that indicate how sure they are of their decision. Do they know enough about the benefits and harms? Are they clear about which benefits and harms are most important to them? Do they have enough support and advice from others? And others could be their healthcare practitioner, their families, their friends. And do they feel sure about the best choice? Step 4 is a formal question that asks people, what do you want to do next? Would you like to try the spinal manipulative therapy, decline it, or choose something else? You can see after filling this out that there would be very specific questions or comments that the person would have to take to their healthcare practitioner. As I said before, we base the interventions, the evidence behind each option on a summary of findings table. So here I've put up a slide that shows what the summary findings table looks like. So it gives an indication of the population, the setting, the intervention, and any comparisons. Then going from the left column to the right, it gives the outcomes. What can people expect? What will be the recovery at 1 month? or the serious adverse events. We give in the next two columns, we say what the risk is without treatment or with the comparison, and what the benefits and harms will be with the treatment. Okay. Okay. The next, we give some relative effect information. The next column is the number of participants that were studied. So you can see here that 117 people were included in this review from 2 studies. So this gives you an idea of the degree or the size of the evidence base. Then we give the quality of the evidence using the grade framework, and in this case it's low quality, which means that further research is very likely to have an impact on how confident we are in this estimate, so further research is likely to change the estimate. And then we've got some comments, and oftentimes the comments might be very useful and give a lot more information, so it shows things like the harms and any other information about the studies. So with most reviews that are currently published, most authors are trying to put a table that looks like this in their systematic reviews, so that people can make an at-a-glance viewing of what the evidence is. I see we have a blank slide here. Okay, here we have, I would just like to pause and ask if anybody has any questions at this point. And maybe I'll turn it over to Erin to moderate the question.
Great, thanks a lot, Tamara. We have one question that Corinne has written through to the chat room. Corinne has asked, do you think the cost of treatments should be included in the decision-making process?
Thanks, Corinne, for that question. I think that at this point we have no plans to put cost in terms of the patient's values of whether it should weigh into their decision, because we're trying to make the decision aid useful across settings. And so in some settings cost will be a factor, and in others they won't. But certainly we do have an area in the decision aid for people to write in preferences or values that may not be reflected. And at this point, that would be where this type of thing, the idea of cost would go.
Thanks a lot, Tamara. Jordi's written into the chat room that cost may be a barrier for usage, but it does not matter for some people. Cost may be an example of some of the values to take into account, but by no means we need to systematically include costs. Thanks a lot for adding that, Jordi. For anybody who's having technical difficulties, I've seen a couple of comments coming through. Just to let you know, all of the slides will be sent through to everybody who signed up for today's webinar. So everybody who signed up, sent us their email, and joined today, you'll get a copy of the slides afterwards. So please ignore some of those technical difficulties that we've had. If anybody else has any other questions, we'll wait just another moment for you to type them through into the chat room. So if you have any other questions, please feel free to type those through, or to raise your hand if you'd like to speak. It looks as though Colin has a question. Colin, I'd like to turn the microphone over to you. For you to speak, please click the talk button to turn on. Click it again to turn off. So Colin, if you have a question, please go ahead now. Okay, it appears as though Colin doesn't have a question. Oh, there we go. What is the evaluation process? Do patients evaluate the decision aid? So Tamara, if you could answer that. What is the evaluation process? Do patients evaluate the decision aid? Thank you.
Thanks, Colin. Patients were involved in the development of the decision aid, and also we do an evaluation process where we send the decision aid out, and we're evaluating mainly for the usefulness and usability, so whether they found that it was useful to their need, whether they could understand it properly, and that type of thing. There is an evaluation, a formal evaluation we've just completed actually with a number of patients in Toronto, and we should be publishing an evaluation probably in this year. Patients do evaluate the decision aid, and they actually are involved in the creation of it as well.
Thank you, Tamara. Colleen, did you have a question as well? If you had a question, please feel free to type it through to the chat room. We'll just give a moment for anybody else to type in a question. Colleen, please feel free to go ahead. Okay, I don't see any other questions coming through, Tamara, so if you wanted to continue, please do.
Okay, thanks a lot, Erin, and thanks for your question. If I didn't answer it, we'll have time at the end also to revisit any other questions too. Okay, so at this point, we just want to ask how you feel now about decision aids. Choose the option that is closer to your current situation. So, Erin, if you can put the, yes, there you go. Just choose A, B, C, or D. So after we've had this short discussion, we'll go on to another example in a moment, but we just want to gauge how people are feeling at this point. Great, we see a lot of things coming through here, which is terrific. Wonderful. So I can see here that a couple of people have a very clear idea of decision aids. The majority of people know what a decision aid is and will have the chance to try it, or will try it if they had the chance. And about 4 people still have sort of an idea, but still are having trouble understanding how it works. So we're going to go through another example for the minority of people there. And strangely enough, everybody, nobody thought it was about hearing aids, so it was perfect. Thank you very much. Okay, so in our last case, Janet discusses the spinal manipulative therapy using the decision aid as a guide, so she went ahead with it. But what about situations where there's more than one option? So this is fine if you're very interested in the interventions that you're studying, but what about a chronic condition where there might be more than one option? I present another case study about Paul. He's 55. He's got sore knees, so osteoarthritis of the knees. He has trouble when he moves around a lot, when he squats or descends stairs. He becomes stiff if he stays in one position too long, and it kind of hurts more in the morning. He occasionally feels as if one of his knees would give out or there's not a lot of stability or mobility there. Paul's doctor says there are several options for osteoarthritis that might help. So just as in the decision aid we showed before, this decision aid in step 1 will help weigh the benefits and harms of each option, clarify the reasons for choosing the options that matter most to him. It will help him decide what else is needed for preparation for decision making, and it will help him decide what his next steps will be. Here's an example of the introduction and background for this decision aid. It lets people know what osteoarthritis is. And also, we like to have people explain or do a self-check on how their joint pain and functionality has been in the week that they're trying this decision aid. They can orient how their symptoms are. And it gives some idea to the practitioner also about how they're feeling and maybe what's prompted them to think about other options. Here's an example of a list of interventions. And we'll come into this more deeply in a few minutes, but in the first column, you can see that it goes from level 0 all the way to level 5. And those are sort of in order of interventions that may not have a lot of effectiveness, but probably won't be very harmful either, all the way up to more invasive, more serious, stronger interventions, culminating in the decision to perhaps see a surgeon about a joint replacement. So we're asking people what they do now and getting them to position themselves in those interventions, and also what have they been doing in terms of their lifestyle in the past week. And so then we sort of start to explain to them that they have an option to make no change or make a change. Here's some more in detail about the options. So as I mentioned before, level 0, these options have the same benefits and harms as a placebo. So you may see some improvement, but you'll probably see the same amount of improvement with the comparison. And then as you go down, the options work a bit better and still avoid serious harm. But as you get to level 3 and level 4, you are facing more serious harms to consider, but also you can expect possibly more benefit as well. So again, these are a visual representation of what the research shows. As with our first example, 100 faces illustrates the benefit of the intervention. So this graphic is meant to show that this is in a case of 100 people, 30 might get better on their own, 21 would improve due to their treatment, and 49 would not improve. So it gives a realistic view of what the expectation for treatment would be. And again, we want people to rate the reasons or their values when it comes to treatment. So how important is it to get better pain relief, to avoid taking pills, perhaps to avoid needles in the case of joint injection, to avoid some of the harms mentioned like a bleeding ulcer or a heart attack, or to avoid withdrawal symptoms in the case of some pain medication. As with the first example, we give a range, we give a question so people can sort of self-administer their knowledge level so that they can test to see whether they've understood which options have the most benefit and which ones carry some harm that they should consider. And as I mentioned before, this is sort of a self-administered just to make sure that people understood the evidence. And then, as before, we find out how comfortable they are about deciding, or whether the presentation of all these options has just made them more confused. So we're really gauging their readiness to make a decision at the bottom of step 3. In this case, we ask people to make a list of their next steps, because there's more than one option to choose from. They may choose a combination of options. They may choose to stay with the plan that they're on now. But overall, they've been introduced to more options for their osteoarthritis. One other aspect of a decision aid might be a one-page clinical summary of the person's answers. So because the decision aids generally are 4 pages in length when they're printed out, they may not be that suitable for a clinical encounter. So some healthcare practitioners may not have a lot of time to go over all 4 pages. So in some cases, we're able to make a one-page summary of their responses. And this gives an idea, and a one-page summary gives an idea to the practitioner about where the person needs more information, what kind of options they might be considering, and any gaps in their knowledge or values or information needs that they might have. In Paul's case, he was able to narrow down the options and discuss his interests. He was able to rule out other options for now, and this idea that a person can rule out things can help if the person is overwhelmed by information and opinions from other people, such as their friends or family, kind of thing. So after doing the decision aid, Paul shows good knowledge about the options. he is motivated. He's indicated that he's motivated to make a change. He's indicated that pain relief is his main objective, and he decides to discuss NSAIDs, a medication, with his doctor. So this second example is just another way that we show how decision aids work and what practitioners and patients can expect in terms of shared decision making. So I just wanted to give some acknowledgments to the people that helped with these decision aids. So people that were involved with the format and standards for the decision aid, people who helped gather up the evidence and gave the patient perspective, a rheumatologist who gave a clinical review, and some funding sources that we had from the Canadian Arthritis Network and from the Canadian Institute of Health Research. So that concludes the formal aspects of the presentation. As I just did, wanted to acknowledge some of the experts that helped develop the decision aid we showed today. So I'll just put up the next slide. To see other decision aids that we have available, you just click on this link, or you can Google decision aid, Cochrane decision aids, and it should be the first link that comes up. So I'm very happy to take more questions now, or hear comments that people have about it. These are definitely a work in progress, and we continue to develop them, so I am interested in your feedback also.
Before we take questions, I'd like to ask everybody to send through a round of applause using your emoticon to thank Tamara for her presentation today. Tamara, I really appreciate you taking the time to come and present today. And I see that there are a lot of questions coming through. So to make things really simple to handle those questions, if you could please type your questions into the chat room. So if you could please type your questions into the chat room. It'll make it a lot easier than handing microphones. So we'll give a few moments for those questions to come through. In the meantime, I have just put a link into the chat room that everybody can click on. And that link is to our evaluation form. So while we're waiting for these questions to come through, if you could please take a moment to go to that evaluation link, we'd really appreciate your feedback so that we know what presentations are working, what formats are working, and so forth. Tamara, there was a question that came through the chat room from Marie, who asked, what is the latest evidence showing the benefits of decision aids as a knowledge tool compared to other knowledge translation methods like quality indicators or practice guidelines? And Jordi kindly responded letting us know that there's a Cochrane review that looks at decision aids for people facing health treatment or screening decisions. And Jordi's pasted that link into the chat room. But Tamara, I wondered if you might have any other response that you'd like to provide to Marie about what is the latest evidence showing the benefits of decision aids as a knowledge tool. How do decision aids compare to other knowledge tools? Tamara, if you could answer that, please.
Thanks a lot, Erin, and also for the question. I agree. For more in-depth evidence, then the link that Jordi pointed out is a Cochrane review of the effectiveness of decision aids, and they do show some benefit for some outcomes, such as readiness for decision making and reducing people's decisional conflict, it's called, so their confidence when they're making a decision. I would have to go to the review to find out what the comparators are, like, as you mentioned, quality indicators or practice guidelines. So, I mean, the main difference in this case is that these are meant for patients and practitioners together versus some other tools that might just be focused on one group or another. I hope that answers the question.
Thanks a lot, Tamara. There was also a question from Luke, who has asked, has timely response to care been looked at in the studies reviewed? If outcomes are similar between modalities after 1 month, but pain relief is much more rapid with one therapy over others, this may factor in your decisions. So Tamara, I wonder if you could respond to that.
Yes, thank you for the question. That is one aspect of taking evidence from from randomized controlled trials, because they do tend to be very short in their follow-up. And the full review would give more of a example or more detail in terms of the comparisons and the length of follow-up. When we do a summary findings table, we're really trying to give our best estimate after taking all the studies in together to cope with those differences in the rate of relief being more rapid than with one therapy over another. So it can definitely be a factor in decisions.
Great, thank you. The last question that we have in the chat room is from Colin, who asked, for evidence not specifically addressed in a Cochrane review, does the Cochrane collaboration have a formal evidence gathering process where you document the evidence to support each statement in a decision aid? Is this publicly available? Tamara?
Hi, thanks for the question. I'm just reading it over here to make sure I understand correctly. The decision aid reports evidence from a Cochrane review. There are a number of Cochrane initiatives to tackle priority settings. So if there are some interventions or populations that the public feels are very important, then there are ways of commenting on reviews and putting sort of responding to them within the Cochrane library. The evidence gathering process for Cochrane reviews is very thorough, so they do look for published, unpublished trials and things that are maybe not published in English. So the evidence gathering process is very, very broad, but the second part of the question is does the Cochrane collaboration have a formal evidence gathering process documenting the evidence to support each statement and decision aid? Yes, the decision aid is based on what's gathered through the broad process in a Cochrane review. Is it publicly available? In some jurisdictions it is publicly available, but the abstract, plain language summary, and if a review has a summary findings table, it's also available publicly, yes. And it's available on the Cochrane Library, and the URL is cochranelibrary.com.
Thanks very much, Tamara. Craig's expanded on that just a little bit further, saying that, Colin's expanded on that, saying that he doesn't recall seeing the Cochrane collaboration address the natural history of knee osteoarthritis. So I wonder if you could explain that a little bit. Oh, I see. So you're asking where the evidence for the background information and the non-interventional. Okay, I understand it. So those usually come from the Cochrane review itself, but only in the background information. So yes, you're right. Those are not. They don't have sort of the same evidence. They don't follow the same process because the information just comes from, I guess you would call it, sort of textbooks, expert opinion, that type of thing. It definitely isn't. That type of information usually doesn't come from randomized controlled trials. Great, thanks, Tamara. So just a final reminder about evaluations. I sent the link through the chat room. Again, if you could please take a moment to address those evaluations, it would be most appreciated, because we do use that to decide which speakers to have back, which topics we should cover again, and so forth. So we'd really appreciate you taking a moment to do that. I'd like to do a quick promotion for our next set of webinars. We're currently in the Using Evidence series, so we'll be having a webinar every week for the next month, addressing different topics around how to use evidence from systematic reviews and from the Cochrane Library. Registration is now open, and the website link is provided there. And Tamara, if you'd like to take a moment to respond to Mark's comment. Yes, I had just written a response there. Thank you, Mark. I do agree. The decision aids are trying to pack a lot of information, and so we're looking at electronic formats to make it smoother and more broken down into and easier to navigate rather than a paper version. So
definitely agree that the formatting continues to evolve, let's say.
Thanks, Tamara. So I'll give a few moments for anybody to type through any last questions, but otherwise, thank you so much to everybody for participating today, and thank you very much to Tamara and Jordi for sharing their expertise with us. Really appreciate your time.